Okay. Beyond simple inhibition, multifaceted molecular characterization of anti-VEGF. बहुत लंबा topic है.
So mine is a Bayer-sponsored talk. It's about beyond simple inhibition, multifaceted
5
molecular
minutes show to him here.
characteristics on anti-VEGF. So I'll try to wrap it up. So VEGF signaling pathway is basically pathological. It results in angiogenesis. We know there are VEGF1, VEGF2 receptors, and VEGF-A, PLGF, VEGF-B. These are the molecules which activate them and cause inflammation, neovascularization, retinal vascular leakage. Now, VEGF, anti-VEGF agents are tested mainly in like these 5 factors: binding affinity, half-life, potency, clinical targets, and molar dose. So binding affinity is basically determined by something called KD, or dissociation equilibrium constant. The lower that is, the higher the affinity is, and that's what we want. So aflibercept here has the lowest compared to, which is then comes brolucizumab, and ranibizumab, faricimab are similar. Coming to IC, or this is the potency. Again, the lower that is, the higher the potency the molecule will have. Here again, aflibercept stands out as compared to the rest of the molecules. Now, half-life again, if we see, it's basically how long a drug stays in your eye, and it's quite comparable to the others, but again, it is much more significant as compared to the other molecules. Target molecule. Now here we have single target molecules which are brolucizumab and ranibizumab. A dual target is faricimab, which is VEGF and Ang2, and multifaceted, that's what we meant, like four targets: VEGF, PLGF, VEGF-B, and galactine. Now, aflibercept targets VEGF, which is the master regulator, as a result, but along with that, it additionally targets the PLGF, and that's how the extended the effect that we have with the aflibercept. We know that there is a great fold increase in DME of these VEGF and PLGF levels, which comes down to a significant level with just one shot. But again here, as long as PLGF is not targeted, it again upregulates the VEGF. So hence it's important to target PLGF as well. Now, could targeting additional pathways beyond VEGFR result in improved efficacy or outcomes? So there are all these different molecules that you can target. Aflibercept targets these 4, and there have been studies targeting the platelet-derived growth factors with eye drops and intravitreal injections, and they've shown no extra benefit. So coming to the newest, does Ang2 have an extra edge? This is a document from the FDA open source website. Here it says that the faricimab is a humanized bispecific IgG monoclonal antibody directed against VEGF and Ang2, and the VEGF antigen binding fragment is identical to ranibizumab, and the contribution of Ang2 inhibition to the treatment effect and clinical spots of neovascular AMD in DME is yet to be established. So is the Ang2 tie to pathway, which is the tyrosine kinase pathway, relevant target for treatment in exudative retinal disease? During angiogenesis, the Ang2 is upregulated and competitively binds Tie2. Now, many studies have shown that Ang2, there is a response when we target Ang2, but there are some studies which show that basically it causes stabilization of the vessels by blocking the Ang2 receptor. Now, some studies show that in high VEGF states, the Ang2 has an antagonistic effect, which may promote, in fact, destabilization. And in lower VEGF states, it may have very limited or even no role because already the VEGF load is low. Now, aflibercept here is the most potent binder of VEGF compared to others because of the PLGF effect. Bayer and Regeneron have themselves done their trials on Ang2 antagonist, which is nesvacumab. Now, the affinity of nesvacumab, for a reference, the tyrosine kinase affinity for Ang2 is 3000, and nesvacumab has a stronger affinity than faricimab, but yet they did not see any additional benefit when they, as compared to aflibercept monotherapy when they used them, Ruby and Onyx trials, and hence they were discontinued. Now the studies.
You see, this trial was a superiority trial. This trial, what you are quoting, Ruby and Onyx, they are superiority trials, not in non-inferiority trials. Yeah. So there's a difference between all the trials, whatever we are, quoted, misquoted, are non-inferiority trials. And this Ruby and Onyx was superior. They wanted that maybe this is superior. उन दोनों बहुत फर्क आ जाता है.
So ultimate outcome was it was non-inferior then to the monotherapy.
Yeah.
So basically, the trials that have supported faricimab, more or less at the end point, 56 week or 46 week, the letter gain was almost similar. Now, faricimab phase 2 trials, ranibizumab and faricimab achieved similar levels of plasma Ang2 with just one injection. A single dose of ranibizumab 0.5 mg reduced the plasma, which is the lower level of quantification, to with just a single dose. So data suggests that anti-VEGF monotherapy neutralizes Ang2 levels and to levels comparable to that directly targeting Ang2, supporting that known biological active Ang2 basically is activity is downregulated by decreasing VEGF levels itself only. So aflibercept as compared to brolucizumab and ranibizumab, it prevents the anti-VEGF basically driven Ang2 production much better than the brolucizumab and ranibizumab. This effect is greater and persists longer with aflibercept versus brolucizumab and ranibizumab. So the results of this study basically support that hypothesis that Ang2
what are you
may
trying to
be
say?
expressed.
Aflibercept shows suppression of Ang2.
So there are studies which say that the VEGF-A, when you control that, so Ang2 is produced secondarily to the
meaning
elevated
thereby
VEGF-A
if you
levels.
suppress VEGF, that also gets
So that
suppressed.
automatically goes down.
But it's not an independent.
It's not a direct Ang2 suppressor. So that's what they're trying to say, that may not be required. So the activator.
So therefore, the effect what you are saying of faricimab is by and large equivalent to that of ranibizumab.
I'm coming to that. Yeah. So the activity of faricimab, what we have seen is that it has a prolonged effect. So hence, it is lesser number of injections as compared to ranibizumab. Now here, when you see that the binding affinity, the estimated half-life, everything is similar to ranibizumab. The only thing that differs here is the equivalent molar dose. So as a result, since there is clinical data to suggest that Ang2 may not have that extra edge, it could possibly be that the higher molar dose of ranibizumab, the Fab arm, may be responsible for the faricimab effect. So with aflibercept 2 mg already targeting key ligands of master regulators, the VEGF pathway, there may be limited potential for improvement in functional outcomes for patients. Summarizing all of them, aflibercept in all these criteria is superior to all the other molecules. The only where it stays back is the molar dose, and which is more in faricimab, which is more in brolucizumab, which probably is what they're trying to say is that which probably is the reason why we get that faricimab effect. And
that effect is primarily duration. That effect is duration.
Exactly. And that again has, with further trials which I have not mentioned here, so I'm going to conclude with that. With further trials, we've seen that Eylea HD is kind of equivalent to the faricimab effect as well. So I think I'll leave that to the summary slide so for everybody to see. Thank you.
I hope there are no Roche people here, otherwise they'll kill you here only. because if you say there's no Ang2 at all, वो तो सारा studies ही Ang2 पे होता है.
Sir, nobody can say there is or there isn't. There are studies supporting it and there are studies opposing it.
So हम कहाँ जाएं?
So
where do we go?
अपनी literature search करके experience से.
Sponsored talk means that you take a neutral stand.
No, so basically the thing is that I believe in this molecule and I've used it, and I've used a lot of faricimab as well. And being say an unbiased.
So let me ask you a direct question. You prefer faricimab or you prefer aflibercept?
I prefer Eylea in general, but wherever Eylea fails, I prefer Pegenex. So that's what I'm trying to say.
So faricimab has no role according to you.
So I mean,
why were you disillusioned by faricimab? What did you see that you got disillusioned by it?
So I've used it in cases, basically I've not used it in treatment naive cases, let me be honest about that. I've used it in only treatment resistant cases.
Which patient are you talking of?
So
faricimab?
faricimab. CNVM patients and a lot of polyp cases. And I've not really seen, I mean, compared to either one of them. So because of the patient support program, I'm a
Honestly,
big
Veer Singh, before I think you make any statement, you should have a comparative data in treatment naive. Otherwise, I don't think so. You can make any statement. You should not.
So basically, this comparative data is the basis of what the theoretical part is.
What
And
I
my
would,
experience is
what I would
obviously a
advise
separate
is,
thing.
what I would advise is, you have a lot of patients in your hospital. You do a comparative real-world scenario.
Yeah, of course.
In real-world scenario between this faricimab and this, then come out.
Of course, sir. When I have that amount of
Next
data, I
time
will
we'll hear
definitely
that.
do it.
Next time we'll
When I
hear
have
that.
that amount of data, of course, I will do that.
And in treatment naive cases.
Yeah.
In treatment naive
Any
cases,
other
sir,
comment
maybe
by
a
anybody or-
far-fetched idea.
A chronic case may not respond to anything.
So, that may be a far-fetched idea because of the costing. I don't think that's realistically a possibility to do treatment naive cases with faricimab.
But you see, all these studies of faricimab or even Pagenex, you see, what I tell all these people is, they always compare with aflibercept only. All of them have compared non-inferiority with aflibercept. Indirect evidence saying that aflibercept my baap hai, uske saath hi hum compare kar rahe hain. That's what you are saying.
So Pagenex is also a very good molecule. In my practice, I think at the moment, faricimab doesn't have a space.
Does not have a space.
Does not have any place.
Ajay, both the Ajays.
So see, standard of care,
Answer,
right?
you agree or not? Yes or no, or you want to modify?
No, I would, since it's a new kid on the block, I would definitely like to try, and I've tried in 2 cases. And I would like to try it in few more cases
How
before
was
I
it
say
result
that
in
I
2
don't
cases?
believe in it.
How was it result in 2 cases?
I tried in a PCV case, it did not work.
So 50% it worked.
So it did not work in PCV.
Ajay, Arora?
In diabetic case, the first injection did not work. So I was disillusioned, but the second injection was patient support free injection. I gave it. And after,
Because it was free.
After, yes. And after the second injection, the effect started coming gradually. And this patient was responding only and only to Ozurdex, to no other molecule. So now when the effect has come after a few weeks of second injection, I've decided to go ahead with all 5. So I've just injected third few weeks back.
Ajay Arora?
Faricimab does work, but it doesn't have a wow effect which was promised earlier. It doesn't have that wow effect. So I have used in a few cases. It does work, but it is not as effective. So my go-to molecule still is Eylea. I do use Pagenex where nothing else is working. Pagenex does give a wow effect. The Pagenex, only thing we are concerned about is whether it will cause an intraocular inflammation. So I just pray when I have injected Pagenex in my patients.
So my disclaimer, I have not used in any, I've only used in AMD. So more specifically PCV.
So next time Veer Singh will hear from you your real world.
Sure, sir.
Okay, I think any comment from the house? We'll otherwise wind up this.